speak about cervical spondylosis, neck pains. This is, as mentioned earlier, a topic close to my heart. I've been trained to do cervical surgery, but over the years the demand is increasing. We speak about this time we're going to bore you with surgical management of cervical spondylosis, bearing in mind that we spoke about different modalities of conservative treatment. The first indication for surgery for the neck is myelopathy. Any functional disturbances and/or pathological change in the spinal cord. This is the wide definition of myelopathy. In specific details, spinal cord compression causing a progressive neurological deficit. The patient needs to be fit for surgery, and loads of research saying that to have a successful outcome, the history is not to be more than 2 years of pain. Few papers reveal that if you are interfering after 2 years, the outcome or the good outcome is negligible. Another indication is radiculopathy. This is the disease of the nerve root. If the arm pain is worse than the neck pain, if the examination reveals only one root affected, and if imaging confirms the involvement of the same root, as mentioned by our radiologist, you need to correlate the clinical examination with the radiological finding. Again, the emphasis on the fact that no operation before 6 weeks of pain. We have to give a chance for the conservative treatment over the first 6 weeks of radiculopathy. Factors to be considered affecting the decision to operate. These are the factors for surgery and against surgery. If the problem is severe, if the history is short, if the neurology is progressive, you have imaging to support the clinical examination, and if he's a young active person. Against surgery, if the problem is mild, history more than 2 years, the condition is stable, not progressive, the imaging are not correlating with the clinical examination, the patient is old. Again, one of our colleagues raised the fact of osteoporosis. This is very crucial when it comes to fixation. In surgery, we try to shy away from osteoporotic older patients. And obviously, poor surgical risk with comorbidities. We're going to touch a little bit about the pathological processes. I guess by now we spoke about the protrusion of the nucleus pulposus. Again, be considering there is not only the disc itself. You can have dislocated fragment of the annular cartilage. Osteophytes are very important when you look into plain X-rays. And obviously the site of these osteophytes, whether from the uncinate process or into the retrovertebral body. This is just a diagram to demonstrate the disc prolapses, the osteophyte formation, and the compromise on the neural canal. Now, so choosing your surgical approach, is the main compression anterior or posterior? This is a question that you need to ask yourself. Is the cervical spine in kyphosis or lordosis? Remember, the cervical spine needs to be in lordosis. The rule says that the compressing agent should be removed from the direction of where it compresses. And as a general rule, kyphosis or straightening of the cervical spine indicates anterior approach. How many levels are involved? Is there an element of congenital stenosis? Again, anterior approach results in fusion, and multi-level fusion may cause disabling rigidity of the neck. Bear that in mind. Congenital canal stenosis requires posterior approach. So that's something that when you build the relationship with your radiologist, sit down with him and define exactly the problem before you use your knife. Again, is there any potential instability in the neck? For us, instability means supplemental fixation with plates. So these are all to be considered before we cut. Again, just to summarize, For the posterior approach, we have the multi-levels involvement, spinal lordosis, the compression is posterior, and the patient has congenital stenosis. The anterior approach, which is quite common and popular, 1 to 2 levels involvement. As we demonstrated earlier, if the spine is in kyphosis, we need to regain the lordosis by anterior approach. Cause is anterior, and there is a sign of instability. Again, this is another slide for you to read. Just to emphasize the same point as mentioned earlier. I'm going to touch on it as a technical procedure. Sometimes when you mention to the patient, they say, "Oh, it's a cervical, it's a neck operation." I'm not sure why paralysis always comes to their mind when you speak about cervical spine. I haven't seen a paralysis case over the last 10 years. But so anyway, we need to reassure them that it's a short transverse incision, not more than 3 to 4 centimeters. The patients are not in a lot of pain after the procedure. Some of them actually they demand to go the second day home to sleep in their beds because they are not in pain. There is not much muscles to harm as you approach it. Let's say the most common pathology is C5, C6. As a landmark, you have between C5, C6 the intersection of the omohyoid and the sternocleidomastoid muscle. The carotid artery pulsations are felt, deeper layers of the cervical fascia are opened, medial to it. So these are things that as you go in, you are taking the carotid to one side, the trachea to another side. Larynx, trachea, and esophagus are retracted medially while the carotid is retracted laterally. And then you are down to the cervical spine. The approach takes 10 minutes, and directly you are into the prevertebral fascia, is divided, and you need to check the level. So as you are in, this is a typical case, C5, C6 disc prolapse, and this is intraoperative imaging. You put a needle and you check that you are on the right level. As my seniors used to say, there's only one thing can go wrong in spinal surgery is to get the level wrong. Anatomical diagram from just to demonstrate trachea, the larynx to one side, carotids are on the other side. Normally I don't ligate these vessels unless they are in the way. I just keep everything as it is and go down to the prevertebral fascia. Obviously, we asked for special instrumentation, and kindly they provided us at the Zahra, simple retractors, and you are into the disc space. We use, as you take the disc out, use the vertebral spreader. It's inserted into the disc space, causing distraction to obtain adequate access, because most of the time the whole disc is prolapsed. We use the Casper retractor, take all the disc spaces in and get down to the PLL, posterior longitudinal ligament. It's very recommended when you read the surgical books to take the PLL out so that you can identify the spinal cord underneath, free the nerves on both sides of the recesses, and make sure that you've done the complete decompression. These are just screws we use intra-op and distract the space, open it up so that you can access the posterior part of we use a burr or electric drill to prepare the end plates. Very important because we use, as a general rule, we use cages so that they can fuse. For them to fuse, you need to prepare the end plates properly. Again, not to be too generous with that. You don't want to compromise that and cause subsidence. Sometimes if you have myelopathy and there is the disc space, taking the disc out is not enough. You can extend it to taking or carpectomy, or what they call the trench procedure. Grafting, it went into loads of stages. We use it to encourage fusion, maintain the height of the disc space, preserve the lordotic curve of the cervical spine, and it's indicated when there is instability. If you are reoperating with pseudoarthrosis history, if there is severe foraminal stenosis due to narrow disc space, and when there is kyphosis. When I started training, we used to rely on autograft from the sacroiliac joint. The general agreement has been that nothing better than the patient's own bone, except in case of osteoporosis. But bear in mind that neuronal side complications are very significant. So most of the time, after 3 months, the patient completely forgets about the neck pain, and he comes with pelvic pain. Haven't used that, I have to admit, over the last 10 years. I've been using other manufactured materials. There are loads in the market, at least 18 types, and you need to make up your mind which type you need to use and which one is convincing to your mind regarding the future. Again, plate or not plate, once you put the cage on, do you want to supplement it with a plate or not? There are loads of factors to be considered, but mainly instability. If you feel there is instability, you need to supplement it with a plate. If the patient is stable after the operation, you can rely on the cage alone. The advantages of using a plate as a supplement: you don't have to use a color after the cervical color after the operation. The probability of fusion is increased, as it's mentioned in the literature, and the risk of postoperative kyphosis, pseudoarthrosis, graft extrusion are reduced. The disadvantage, obviously, of the plate is that you have the increased evidence of dysphagia, infection, and screw loosening. An example of a case, C5, C6 again, and C6, C7. We do an MRI scan that confirms the 2 levels, and that's an axial view, mainly compromising the right side. And that's his postoperative level. I do use certain cages, the trabecular metal cages. Yes, these are the ones that I've been using for the last 10 years. It's a genius manufactured sort of cages. They simulate cancellous bone, and basically when I prepare the end plates, I just leave the cage in and come out. I use soft color for 10 days, and when the patient comes after 10 days to the clinic, make sure that the sutures are out and I take the color out. The benefit of the trabecular metal cages is that they are osteoconductive. They have flexibility similar to cancellous bone, biocompatibility to the patient himself. It's quite stable the way it's made, and the strength, high compression strength, allows the trabecular metal to stand physiological loading. What other modalities of treatment when it comes to disc problems? There is now, for the last 7 years, there is the disc replacement procedures. Again, there are loads on the market as different manufacturers. You need to trust one manufacturer and use it. It has been studied that with the trabecular metal, I have an experience with the Pro Disc C disc replacement, and according to the data, the cervical disc replacement has better range of movement as expected in comparison to anterior cervical decompression and fusion. The technique is similar, a little bit of variation. You put the patient in a little bit more lordotic neutral position. We stabilize the neck before we start our surgery. We take the head and the chin, and there is no rotation. We need your patient to be quite stable on the table before you put your disc replacement. I don't think that would run. This was be a video. But anyway, you take my word. You need to try it first. Use a mill, and then you insert your disc. There is different stages about it. Does it come without the price? Nothing comes without the price. There is a subsidence incidence, so that's why most people who do disc replacement regularly, they do DEXA scan throughout osteoporosis. You can't put a disc replacement in an osteoporotic patient. It depends on the surgical technique. Again, the interplate integrity is very important when you seat your prosthesis. They say that what we call neighboring segment involvement after disc replacement is less with disc replacement. Again, they say that the negative disability index scores are better after the disc replacement in comparison to anterior cervical fusion. Multi-level, single-level, the people who do it on a regular basis, they say even you can do disc replacement into multi-level. The problem with the private sector is that the reimbursement from the insurance companies are quite high, so the insurance are a bit reluctant to pay for disc replacement in comparison to a cheaper option of fusion. Obviously, if you have a young patient, a single-level disc problem, you can fight his case and say he needs a disc replacement, and that's in his favor for the future. And there now research is supporting that approach. Again, tropic ossifications that sometimes come with disc replacement. They say it has to do with your aggressiveness during the surgery. So you need to be quite respecting to the soft tissues when you put it. Again, it's not known. Would you go for cervical disc replacement? Would it go for normalization of load transfer? The answer is yes. Maintenance of mobility, yes. Protection of adjacent segments, query, yes, but the evidence is saying that it has improved, does reduce the adjacent segment degeneration. So there is pros and cons of every procedure, but it's there on the market that we need to think of. Move on to the posterior operation. The secret for posterior midline approach is to keep exactly to the midline, which is relatively avascular. Surgeons will tell you that their enemy is bleeding during the operation. Correct positioning of the patient on the table. It depends on how many levels you are approaching. Microscopic discectomy and furomatomy is valid at one level, 1 to 2 centimeter incision. Use X-rays to verify your position. Muscle is detached, and use certain what we call Williams retractors, and get down to the level involved and do your furomatomy and discectomy. The disc is not that difficult to approach. Once you take the approach for the disc prolapse, the laminotomy is extended medially. The ligament in plane and below protects the canal need to be removed, and then down to the disc space. We're going to move on to if there is multiple level, which is mostly involved, multi-level stenosis or problems, you need to think of decompressive laminotomy. Both sides of the spine is taken, using a drill. Correct positioning at the junction of the lamina and the lateral mass is important so that you don't destabilize the spine. So basically sparing the joints here and just go into that junction. Once you've done that, you can elevate it and expose your cord and do you've done your decompression. The supposed disadvantage of laminectomy is that it may produce instability and iatrogenic spondylolisthesis. In practice, if the facet remains intact, the risk of instability is minimal. So that's very important. This is a case we did just before I came to the Emirates. She had multiple disc involvement, severe degeneration, and this is not obviously for anterior approach. This is how you position on the table. And as we mentioned earlier, this is an MRI scan, more than one level, and you do the posterior approach and decompress. If you feel like there is any sign of instability, immediately you think of stabilization. Okay, it's something that you don't think twice about. Once you feel like you are compromising the facet joint, you just put your screws in and stabilize. This is her post-op X-rays. Okay, you've done your decompression, the cord is happy, and then you stabilize the neck with a couple of vertebral masses. Thank you very much.